Hey buddies, welcome back to our series on the benign prostatic hyperplasia or BPH. In our previous video, we laid the foundation by covering what BPH is, a benign enlargement of thin prostate. We discussed its causes, common urinary symptoms and the underlying pathology and pathophysiology and the anatomy of the prostate gland. Now that you understand what's happening, let's move on to how we actually detect and manage the BPH in real world clinical practice. As we discussed in our previous video, the primary symptoms of the BPH arises because of difficulty in voiding the urine due to obstruction of the urethra by the enlarged prostate. They consist of hesitancy, poor urinary flow, and sensation of incomplete emptying. Other symptoms include urinary frequency, urgency of micturition, and urge incontinence. Although these are not specific to BPH, some patients present suddenly with the acute urinary retention when they are unable to micturate and develop a painful distended bladder. This is often precipitated by excessive alcohol intake, constipation, and prostatic infection. Severity of the symptoms can be ascertained by using the International Prostate Symptom Score questionnaire IPSS, which serves as a valuable starting point of assessing the patient. Once a baseline value is established, any improvement or deteriorations may be monitored on subsequent visits. The IPSS may be combined with the quality of life score, in which patients are asked the following questions. If you were to spend the rest of your life with your urinary conditions the way it is now, how would you feel about that? The response ranges from the 0, means delighted, to the 6, that is terrible. Going bit deeper into the history, American Urological Association introduced in 1998 as an AU symptom score as an standard validated tool to assess the lower urinary tract symptoms LUTS due to BPH, which include the 7 questions that assess the urinary symptoms over the past month. Later on, the IPSS International Prostate Symptom Score is identical to the AU symptom score plus one additional question. It was endorsed by the WHO and International Continence Society to support the global use. And finally, as discussed earlier, quality of the life question is added at the end of this AU symptom score, which became the IPSS. In conclusion, the IPSS is equal to AUVS symptom score plus 1 QoL question, that is quality of life question. Now let's see a bit more on the diagnosis. Prostate gland enlargement does not typically causes problem until after 65 years of age. Diagnosis require assessment of the medical history like surgeries, trauma and the medications, including the herbal and the OTC drugs, and physical examination. The physical examination should include a digital rectal exam DRE to determine the size of the prostate and identify any lumps or the nodules. A urine analysis and the serum prostate specific antigen, that is PSA, are used to rule out the conditions other than the BPH. PSA is an glycoprotein member of the human chelicarine gene family, and this PSA is an serine protease that liquefies the semen in the excretory tracts of prostate. This PSA is increased when the prostate become larger due to the BPH. Though BPH is a benign, which means non-cancerous condition and does not increase the prostate cancer risk. The diagnosis of the BPE is an clinical one, but flow rate can be accurately measured with an flow meter and prostate volume by transurethral ultrasound scan TRUS, and the objective assessment of this obstruction is possibly by the urodynamics, but this is a seldom required. If the symptoms or the signs such as the palpable bladder, nocturnal enuresis, recurrent urinary tract infections, or a history of an renal stones are present, renal function should be assessed. If it is an abnormal, screening should be conducted for the evidence of obstructive nephropathy by ultrasound examination. If you want to assess your symptoms or track your progress, head over to the pharmacy.me and use our free online IPSS score calculator, a simple tool to help you understand the severity of your urinary symptoms and guide your next steps. Don't forget, the earlier you address the symptoms, the better the outcome. Now let's see the treatment principles. When a patient presents with an acute urinary retention, it's urological emergency that requires immediate catheterization to relieve the obstruction. For the patient with a mild to moderate symptoms, the first approach is medical management. The initial line of the treatment includes alpha 1A adrenergic receptors such as tamsulosin, which relaxes the smooth muscles in the prostate and bladder neck, improving the urinary flow. These medications act quickly but do not shrink the prostate. For the patient with the prostate volume over 30 grams or the PSA level above 1.4 milligram per liter, alpha reductase inhibitors like Finasteride or dutasteride may be added. These drugs reduce the dihydrotestosterone and shrink the prostate, but they have the delayed onset of action. The important note here is they should not be used in the men who have the bladder outlet symptoms without prostate enlargement. A combination of alpha blocker and a 5-alpha reductase inhibitors is often more effective than either alone or giving the benefits of both rapid symptom relief and the long-term prostate shrinkage. Additional treatment options include anticholinergic drugs such as tolteridone and beta-3 agonists like mirabegron. These are used in the combination with an alpha blockers when symptoms are predominantly irritative rather than the obstructive, but only in the men who have the postvoidal residue PVR less than 250 to 300 ml to avoid the urinary retention. These medications are especially useful in the cases of overactive bladder and are discussed more detail in the chapter of urinary incontinence. Other useful class is phosphodiesterase inhibitors such as Tadalafil used alone or with the Finasteride. This is a particular attractive option for the man who has both BPH and erectile dysfunction. And if medication fails, then we move to the surgery. The most important procedure is TURP or transurethral resection of their prostate. An effective alternative is holmium laser enucleation, which may offer the fewer complications. The open surgery is now rarely needed, typically reserved for the men with very large prostates. Now let's see the each and every drug category in detail, starting with the alpha blockers. Under alpha blockers, there is selective alpha 1A blocker and non-selective alpha 1 blocker. The non-selective alpha 1 blocker examples are doxazosin and terazosin. The doxazosin is branded as Cardura or Cardura XL. For immediate release preparations, start at 1 milligram at the bedtime, titrate slowly up to the 4 to 8 milligram at bedtime. And coming to the extended release drugs, start at 4 milligram with a breakfast and maximum dose is 8 milligram daily. And coming to the terazosin, start at 1 milligram at the bedtime, titrate slowly to the maximum of 20 milligram at bedtime. A dose of 10 milligram is generally effective. Now let's see selective alpha 1A blockers. Starting with the tamsulosin is branded as an Flomax. The dose is 0.4 milligram daily, taken 30 minutes after the same meal each day. The maximum of 0.8 milligram daily. It is also available in combination with an dutasteride. Coming to the next selective alpha 1A blocker is alfuzosin, that is branded as an Uroxtral, 10 milligram daily, taken immediately after the same meal each day. If creatinine clearance is under 30 ml per minute, use this with a caution. The next selective alpha 1A blocker is silodosin, also branded as an Rapaflo, 8 milligram daily with a meal. If the creatinine clearance is 30 to 50 ml per minute, reduce to 4 milligram daily. And if the creatinine clearance is below 30 ml per minute, do not use it. The contraindications of these drugs are avoid silodosin or alfuzosin with the strong CYP3A4 inhibitors, and contraindicated in the hepatic impairment, avoid use in the child PU class C for silodosin and class B or C for the alfuzosin. These are contraindicated in the severe renal impairment. Things for these drugs include the risk of orthostatic hypotension and syncope, especially with the first dose, or if the therapy is interrupted and restarted. The caution when combined within other antihypertensives or phosphodiesterase 5 inhibitors like sildenafil or tadalafil. And the risk of intraoperative floppy iris syndrome, IFIS, during the cataract surgery seen in the patient currently or previously on the alpha 1 blockers. It may causes the priapism, seek medical attention if an erection lasts greater than 4 hours, and also discontinue if the symptoms of the angina begin or worsen. The side effects of these alpha blockers are dizziness, fatigue, headache, abnormal ejaculation, especially with the tamsulosin and silodosin, fluid retention, and rhinitis with the tamsulosin. The monitoring parameters include monitor a blood pressure, PSA levels, and urinary symptoms. Coming to the safety points, the non-selective drugs are often given at the bedtime to help minimize the initial first dose effects like effect of orthostasis, dizziness. This requires the careful counseling as a nocturia is common, and getting up at the night to use the bathroom can be dangerous if the dizziness and orthostasis occur. Alpha blockers work quickly on the LUTS, but 4 to 6 weeks may be required to assess whether the beneficial effects has been achieved. They do not shrink the prostate and do not change the PSA levels. Cardura XL is an OROS formulation which stands for Osmotic Controlled Release Oral Delivery System and may leave a ghost tablet in the stool. This is harmless. Nothing but empty shell in the stool. Silodosin can cause retrograde ejaculation in around 30% of an patient. This is reversible after stopping the drug. Do not use the alfuzosin in the patient at the risk of QT prolongation. And alpha blockers may be used off-label in bladder outlet obstruction in women. Before we dive into the next class of drugs, please like, share, and subscribe the channel for more medical content. And now we are diving into the powerful group of medication used to treat the symptoms of BPH. Let's break it all down simply and clearly. So, what are 5-alpha reductase inhibitors? These medications work by inhibiting the 5-alpha reductase enzyme, which blocks the conversion of testosterone to dihydrotestosterone or DHT. Since DHT is a key player in the prostate growth, reducing its levels help to relieve the symptoms of BPH. The two main drugs in this class are Finasteride and dutasteride. Coming to the dosing, Finasteride is typically given at 5 mg daily for BPH and 1 mg daily for the hair loss, and dutasteride is taken at 0.5 mg daily. Now let's see safety, side effects, and monitoring. Now let's talk about safety. These meds are contraindicated in pregnant women, women of childbearing age, and children. The warnings of these drugs include they mainly increases the risk of high-grade prostate cancer. So regular monitoring is a key. Side effects include impotence, decreased libido, ejaculation disturbances, breast tenderness or enlargement, rashes, and overall sexual side effects which may improve after 1 year of use. Coming to the monitoring parameters, patients should be monitored using the PSA levels and urine symptoms assessment. And the main and important notes include pregnant women should not take or handle these medication as the active ingredient can be absorbed through the skin from the broken or a crushed tablets and can be detrimental to the fetus. On the NIOSH list of hazardous drugs, delayed onset, treatment for 6 months or longer may be required for minimal efficacy. 5-alpha reductase inhibitors shrink the prostate and decreases the PSA levels. Swallow the dutasteride whole. Do not chew or open as the contents can cause the oropharyngeal irritation. So, to summarize, 5-alpha reductase inhibitors are effective for BPH but come with an important precautions, monitoring requirements, and delayed onset of action. Always consult with your healthcare provider before starting these medications. Thanks for watching so far. If you found this helpful, do not forget to like, subscribe, and share for more clear breakdowns of the clinical topics. Now, let's talk about the other category of the drugs. Those are phosphodiesterase 5 inhibitors or PDE5 inhibitors. Though not fully understood, these drugs are believed to work by decreasing the smooth muscle and endothelial cell proliferation. They reduce the nerve activity and improving the blood flow to the prostate and the bladder by relaxing the smooth muscle. The key player here is Tadalafil. It is only phosphodiesterase inhibitor approved by the FDA for BPH with or without erectile dysfunction. Now let's see the dosing. Tadalafil can be taken alone or in the combination with the Finasteride. The dosing is the standard dose is 5 mg daily at the same time each day. And for the patient with the moderate kidney impairment, where creatinine clearance is 30 to 50 ml per minute, start at the 2.5 milligram with a maximum of 5 milligram daily. For the severe impairment, creatinine clearance less than 30 ml per minute, do not use it. If the patient is on the strong CYP3A4 inhibitors, use 2.5 milligrams of Tadalafil only. These are contraindicated in the patient who is taking the nitrates or Riosiguat, a guanylate cyclase stimulator, due to the risk of dangerous drop in the blood pressure. Impaired color vision, especially in the patients with the retinitis pigmentosa, hearing loss with or without dizziness or ringings in the ear, that is tinnitus, a rare vision loss possibly by non-arteritic anterior ischemic optic nephropathy, especially in those over 50 or with a vascular condition. And also, warning signs include severe hypotension, especially in the patients with a resting blood pressure below 90 by 50 mmHg or fluid depletion. In heart diseases, extra caution is needed. Seek help immediately for the chest pain, priapism, and erection lasting more than 4 hours. Seek a medical emergency help immediately. Common side effects include headache, flushing, dizziness, indigestion or dyspepsia, muscle and back pain, blurred vision, light sensitivity, nosebleeds, and diarrhea. And the patient taking the Tadalafil should have regular checks for blood pressure, PSA levels, and urinary symptoms. Important clinical tip here is Tadalafil should not be combined with an alpha blocker for BPH treatment due to increased risk of hypotension. So while Tadalafil is more famous for treating the erectile dysfunction, it also plays an unique and useful role in the managing the BPH when used carefully and appropriately. If this helped clarifying the things, give it a thumbs up, subscribe for more detailed medical explainers, and comment below if you want us to compare PDE5 inhibitors with other BPH treatments. Let's see key counseling points. For the alpha blockers, can causes the orthostasis. Tell your healthcare provider about the use of this medication if you are having a cataract surgery. For the non-selective alpha blockers like doxazosin and terazosin, to be taken at the bedtime, and the ghost tablet in the stool, which is empty shell in the stool. And for the silodosin, it can causes the sexual dysfunction like retrograde ejaculation. And the counseling point for the 5-alpha reductase inhibitors are, okay, it can causes the sexual dysfunction, decreased libido, ejaculation disturbances, and erectile dysfunction. So avoid in pregnancy, which because of teratogenetic effects. And the women who are or may become pregnant should not handle these tablets. And that brings us to the end of this complete breakdown on the medications used for the benign prostatic hyperplasia or BPH. In this video, we explored two important classes, 5-alpha reductase inhibitors like Finasteride and dutasteride, which work by shrinking the prostate and lowering the DDH levels over time. They are effective but may be taken 6 months to show the full benefits and come with an important side effects, especially related to the sexual function. And then we covered PDE5 inhibitors with the focus on Tadalafil, a drug that not only helps with the erectile dysfunction but also improves the BPH symptoms by relaxing the smooth muscles. It's fast acting but comes with an own cardiovascular warnings and vision related risk. Remember, treatment should always be individualized and monitoring is a key, whether if it's PSA, urinary symptoms, or blood pressure. And above all, these medications are not interchangeable. They work differently and have different precautions. And final thought for this video is BPH is common, but managing it well starts with understanding how each medication works, what it does, and who is its rights for. Whether you are a healthcare student, a patient, or just someone curious, knowledge is power. If you found this helpful, don't forget to like, subscribe, and hit the bell so you'll never miss a breakdown of key medical topics. Got questions or want a comparison of BPH drugs with an alpha blockers next? Drop it in the comment below. Until next time, stay healthy, stay curious. Stay healthy, stay cheesy with Pharmacy Made Easy. Follow for more.